Hi, this is Julie Levinsky. I am the Associate Digital Director for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to the first part of our three-part series for pain medication education. And I'd like to tell you a little about our host. It's Jay Gupta, the Director of Pharmacy and Integrative Health at Harbor Homes in Nashua. I hope I said that right. As well as the MTM consultant and yoga therapist. He's also the co-founder of RxRelax and YogaCaps, where he focuses on chronic disease prevention and sustainable lifestyle change. So now I'd like to turn it over to Jay. Hello, Jay.
Hello, Julie. Thank you so much. Hello, everybody. So it's my pleasure to share what I know about the pain and the pain medications. So as Amy mentioned, that is a three-part series. Today we're going to focus on the pain medications. So just to give you an overview why we are doing this is because pain is one of the most common secondary conditions with spinal cord injuries or spinal cord disorders. Over 90% people with spinal cord injury report an incidence of pain. That's why the proper assessment and treatment of pain is essential. We know the pain is complex and the treatment is also complex, but it's important that we continue to keep the tab on the rapidly changing landscape. So in the last 3 or 4 years with the deaths which happened because of opioid overdoses, the way we looked at pain medication, the way we prescribed them, the way we use them has rapidly changed. So we're going to share some updates throughout this series. If you are going to be listening to this recording later on, I would ask you to actually check for the updates on the information. So those who are on the webinar now, just for your information, we are recording the webinar. It will be available online, and you can go back and check it, but check for the updates as well. Continue to work with your healthcare team and do your own research. So I'm going to give you some more tools so that you can be an educated person. Throughout this webinar, I'm going to be using some generic names of the medications, but also the brand names. Just as a disclosure, I don't work for any of those companies, and I have no personal interest with any of these pharmaceutical companies. One more disclaimer that I have taken some images from the internet, and they are not individually acknowledged. So let's begin. So today's topic would be my pain medication. We'll talk about what the pain is, what is the different types of pains, with a focus on spinal cord injuries and disorders. We'll go over pain medications, overview, and go in detail about some of the medications. We'll talk about safe medication usage and some of the potential resources so you stay updated. Next month, we'll talk about opioids and opioid addiction. So that will be covered in details in the next month. And third module, that's where we will talk about cannabinoids, the marijuana, and all non-pharmacological interventions which can help in tapering the opioids and manage our pain better. So let's jump right in. We'll talk about the pain. According to the International Association for the Study of Pain, IASP, pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage, or is described in terms of such damage. So pain can be acute or chronic. So when the pain resolves within 12 weeks of an injury, a surgery, or an illness, it's called acute pain. If it persists beyond 12 weeks, according to IASP, it is considered chronic. Of course, depending on the database you're looking at, some places will say if it is more than 3 to 6 months, it is considered chronic. In case of chronic illness, chronic pain, we may know the cause, but we may not even know the cause. Sometimes it's just there even after the tissue has healed completely. In some cases, we have acute on chronic, where the acute flare-ups happen on the underlying chronic pain. So looking at the variety of pain, the types of pain, there are two main categories. One is called nociceptive, other one is called neuropathic pain. It's very important to understand the difference between them because the medicines we use for nociceptive as well as neuropathic pain, they're different. Nociceptive pain is the most common type of pain people experience. It develops when the sensory neurons on the skin are triggered, and they could be triggered by inflammation, chemicals, or with a physical injury or any event. Just to give you an example, if I accidentally put my hand on hot stove, the sensory neurons from my hand will send an emergency message to the brain, and brain will fire the motor neurons. So the action coming from the brain will make me remove my hand immediately from the risk. So this is kind of a harm reduction process which is built into our nervous system. If I don't get that reaction from the brain of removing my hand, I can cause more harm otherwise. Another reaction which brain does in response to this trigger of pain is sending more blood flow there. So more white blood cells will go there. So if there's an injury, bacteria might be getting in, our immune system gets kicked in. It will also send more clotting factors or platelets. So if there's a bleeding going on, it will start to clot that bleeding. It also produces some neurotransmitters which work like natural opioids. So most people will describe the nociceptive pain as dull, sharp, aching, tingling, stabbing, nagging, burning, pulsating, or stinging. So we'll talk about the subtypes and how it can be musculoskeletal or visceral in a minute. Let's talk about the neuropathic pain. Neuropathic pain happens when the nerves which are conducting the signal from the source of the injury going up to the brain, they're either damaged or they're sending the pain signal for no reason. So if there's an injury directly to the nerves or for no reason they start to trigger. So that's called neuropathic pain. Mostly the neuropathic pain is described as feeling pins and needles, burning, shooting, stabbing, or numbing. So as I just mentioned, the pain can be very complex. So I normally recommend keeping a written list. So you make your observations, what type of pain it is, where is it located, what triggers and makes it worse or makes it feel better. So all those things which you're going to write down will help when you're discussing your pain with your medical provider. Spinal cord injuries. So people experiencing spinal cord injury, the studies say more than 90% people experience some form of pain. Neuropathic pain is the most common one and is very complex. There are many subtypes of the pain. We'll talk about those. In last 70 years or so, there have been about 30 pain classifications. The most recent one was created by ISCIP, which is International Spinal Cord Injury Pain Classification. What they did in 2012, they had a three-tiered approach. The first tier defines the pain type, as we just talked about. It could be nociceptive or neuropathic pain. There could be some other pains which are for unknown origin and whatnot. The second tier divides the first tier pain into various subtypes. It could be musculoskeletal or visceral. And third type specifies the source of the pain at the organ level or pathological level.
Hey Jay, it's Julie. I've been asked if you could speak up a bit more. Your audio is coming in pretty low.
Oh, okay. Is this a little better?
Yep, thanks.
Great, Julie. Thank you. Okay, so musculoskeletal pain, it involves mostly the muscles, joints, and the bones. Most common affected parts of the body are shoulder, elbow, wrist, and the hands. The pain can be described as dull or aching, and if it is not treated immediately, it can become chronic. So some people will experience musculoskeletal nociceptive pain as part of normal aging. With a normal wear and tear on the musculoskeletal system, it could be in the vertebral column. People who use wheelchair or who have spinal cord injury, they could be putting a lot of pressure and strain during transfers from wheelchair to bed and vice versa. It could be the movements which you are making with pressure relief. It could be wheelchair mobility, over-efforting in any activity, and if the wheelchair is not well fitted, that could also trigger this kind of pain. Technology related, so a lot of people are doing texting and typing, so that can cause that kind of pain in your hands. If you're using a joystick which is operated by hand, it could be by chin or mouth. So that repeated over-efforting or repeated movement can cause this kind of injury. Spasms also happen which are related to spasticity. We'll talk about that. So most cases, if you rest and do not keep repeating that movement, the problem can be resolved. Visceral pain, which is another nociceptive pain, it's mostly in the stomach or the GI area, gastrointestinal area, and they can be related to medical issues like constipation, urinary tract infection, or kidney stones. The neuropathic pain. This is one of the most common pain with people who are experiencing spinal cord injury. Usually people will experience it below the level of injury, but it could be at the level of injury as well. Usually this pain, neuropathic pain, can be made worse by stress, fatigue, spasticity, pressure sores, visceral diseases, smoking, and of course alcohol. So some people use alcohol as a pain medication, but it's definitely not the best thing you can use for better managing your pain. If you happen to experiencing a new pain or emerging medical concern, increase in pain, definitely check with your doctor because this could be something new happening. So medications for pain act through various mechanisms. So there are multiple mechanisms of action. So I'm going to go over the full category and give you a few examples of that. Having said that, we know that there's no simple or single way to treat pain. So a lot of pharmacological and non-pharmacological interventions are available. Today we're going to focus on pharmacological interventions with pain medications. So despite all the treatments and options we have, it is a challenge. It's still a challenge that neuropathic pain is not treated properly, or it does not have effective relief. So please continue to talk to your healthcare team, and if you work with your doctor and your pharmacist and work with them as a team, that will be really awesome because your observations and insights are critical in this whole process. So let's begin the pain medication overview. So I just put all the categories up here. Most of the medications are available on prescription. There's some over the counters as well. So Tylenol or acetaminophen is over the counter. Anti-inflammatories like NSAIDs, in high dose they're available on prescription, and in low dose they're available over the counter. There are pain patches, gels, ointments, and then we'll go over all these categories: COX-2 inhibitors, which are called superaspirins, corticosteroids, muscle relaxants, benzodiazepine, some antidepressants, anticonvulsants or anti-seizure medications, topicals, and low-dose ketamine. So this is being newly used. Ketamine is a very old medication which we used to use for anesthesia, but given in low doses has pretty good results with pain, but we don't have enough data to recommend this medication yet. And of course we'll talk about opioids as well, more in detail in second webinar. And cannabinoids, herbals, non-pharmacological options will be discussed in part 3 of this series. All right, let's look at the first category. The first category here is NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. So as the name says, they reduce the inflammation at the pain site, and they are non-steroidal. So we'll talk about steroids in a few minutes. They also help with fever and pain, not just the inflammation. They're usually used for musculoskeletal pain, and the efficacy of NSAIDs in neuropathic pain is minimal, if any. They're usually used for short-term acute pain, but they could be also used for chronic pain. The most common medications are aspirin, ibuprofen, and naproxen. All these three are available over the counter. However, ibuprofen and naproxen in higher doses, they're available on prescription only. So you might have seen these names or used some of these medications: ketoprofen, diclofenac, ketorolac, indomethacin, piroxicam, meloxicam, which is used only once a day, etodolac. So these are all in the same family of medications. NSAIDs are old. They are very effective in reducing pain and inflammation, but they also have a ceiling effect. What that means is if you continue to increase the dose of the same medicine, it will not help you much. So for example, in case of ibuprofen, the pills we have on prescription are available in 600 milligram as well as 800 milligram, but usually after 400 milligram 3 times a day dose, they're not very effective. So it's probably better to add another medicine instead of keep increasing the dose of the same medicine. Some of the most common side effects of these medications are felt in the belly, the gastrointestinal ulceration and bleeding. So it's strongly recommended when you take any of the NSAIDs, please take them with food. Kidney failure is another side effect, and these medications have high risk of hypertension and cardiovascular events as well. So if you're taking anything over the counter like aspirin or ibuprofen or naproxen, do let your pharmacist and the doctor know so they can put that in your chart, and they will know that they are not giving any medication which will interact with these medications or exacerbate the side effects of these medications. The second category is called COX-2 inhibitors, which are also called as super aspirin. So these medications work similar to NSAIDs, but the side effects are less on the GI tract. So people don't have upset stomach. They don't need to be taken with food. However, I've seen people reporting GI side effects with COX-2 inhibitors as well. So we had 3 medications which were approved by FDA, but 2 of them were taken off the market. So right now we have only Celebrex available. It is generic now, so it's not very expensive the way it used to be, a couple of $100 for a month supply. So it is now available as generic called celecoxib. So celecoxib helps in reducing the pain and inflammation. Acetaminophen. So this is a medication which I hope everybody is familiar with. The common brand name in America is called Tylenol. In European countries, the Panadol is the brand name which is very common. It works pretty good for pain and fever, but has very little effect on inflammation. The biggest problem with this medication is the liver damage. It is metabolized through the liver, so if you take it in the low dose, it's good, but if you are exceeding more than 4 grams per day, it is going to tax your liver. So 4 grams per day is considered the maximum dose. Some sources will actually say keep it below 3 grams, so you're not even taking risk. Alcohol or any other medicine which is processed through the liver, if you're taking those, then also you need to reduce the dose of Tylenol or acetaminophen. As you can see in the slide, poisoning can cause gastroenteritis within hours, but liver failure or liver damage can happen within 1 to 3 days after ingesting high dose of Tylenol. We have currently in America over 600 products which contain acetaminophen. Another problem is acetaminophen is also called APAP, which is an abbreviation for acetyl para-aminophenol. So if you see these 2 labels which I have on the slides here, it says oxycodone/APAP. So 325 milligrams is the acetaminophen here. So if you are traveling outside America and you see a label which contains paracetamol or Panadol, so you are possibly going to be overdosing yourself on this medication. So I just wanted to highlight this so you're keeping it safe for yourself. Okay, so the next category is corticosteroids. So corticosteroids are produced naturally by the adrenal glands in our body. Adrenal glands sit right on top of our kidneys. They help as anti-inflammatory, so they reduce the inflammation in the body after injury or otherwise. 3 medications are commonly used. They're manufactured in the factories, so they're not extracted naturally. It's prednisone, methylprednisolone, and dexamethasone. They're available as tablets or liquid to be taken orally, or they're available as injectables, and those injections can be given intravenous into the bloodstream. Can be injected into the spine or into the joint directly where the pain is. So these medications also have a lot of side effects, but if they're used in short term and then in low dose, the side effects are fewer. If somebody is using these medications for more than 2 weeks, then they need to be tapered slowly. Julie, I see a couple of people raising their hands. Do they have a question or is something else?
They may have a question, and we'll be taking audio questions if time permits at the end. So if you guys can just hang on till then. If not, type your question in the chat box. And just a reminder to speak up, Jay. Thanks.
Okay, Julie, thank you. Okay, so the long-term use of corticosteroids can cause significant side effects, which include adrenal insufficiency, hardening of the arteries, eye problems. It can increase blood sugar. Also, if somebody is diabetic, their blood sugar numbers will be off. It can cause edema because of fluid retention. They are also supposed to be taken with food because they can cause GI bleeding. They reduce the immunity. So we use these steroids to reduce the immunity in autoimmune disorders, but people who are using it for pain or inflammation, they don't want their immunity to be suppressed. Insomnia is also very common with corticosteroids. That's why we recommend if you are taking a steroid, take it earlier in the day. If you're taking in the afternoon or late in the evening, you may not be able to sleep well. It can cause mood changes, can thin your bones called osteoporosis, tissue damage, and weight gain. So a bunch of side effects, so that's why we recommend that corticosteroids are used only in case of flare-ups for short term in the lowest possible dose. The next category of pain medications we have are called muscle relaxants. So these are some of the examples: baclofen, dantrolene, tizanidine, orphanedrine, cyclobenzaprine, methocarbamol, and metoxalone. Some medications which we have been using a lot in the past, diazepam and carisoprodol, they were very popular once upon a time, but in the last few years, because of their addictive potential, we do not recommend them for long-term use. So let's get a little deeper into the details. The first three, baclofen, dantrolene, and tizanidine, are the most commonly used muscle relaxants for people with spinal cord injuries. So all these muscle relaxants have a very common side effect, which is drowsiness or sleepiness. Baclofen is considered the first line in spinal cord injuries. So first line means it's most effective, least side effects, so that needs to be tried first. And if that doesn't work, then we move on to the next agent. So plasticity is when the muscles become stiff, they become heavy, and they're difficult to move. 80% of the spinal cord injury patients, they experience spasticity, and it interferes with daily living, like sleeping, mobility, brushing teeth. So these medications are very useful for that. Baclofen can also be used in the pumps, which can be implanted into the spine. So it's called intrathecal implantation. So it gives high concentration of drug into the target area instead of putting into the bloodstream, so that the side effects of the medicine are minimized. So those adverse side effects are usually seizures, nausea, dizziness, drowsiness, fatigue, mental confusion, and weakness. One thing to remember with many of these medications, including corticosteroids, which we talked about, that they need to be properly tapered. So mostly we start them at a low dose, increase the dose, and then if we want to stop the medication, we want to taper them off slowly so there are no withdrawal symptoms. The second muscle relaxant is called dantrolene. It has a liver warning, so people at the start of the treatment have to check their liver function test. Of course, doctor will do that for you. And at least every 3 months, people need to be monitored for liver function. This becomes first-line medication for somebody who also has not just the spinal cord injury, but also the brain injury. It affects the skeletal muscles directly, and because of that, it causes generalized muscle weakness. So baclofen again stays as the first line for people who do not have brain injury. Tizanidine again is a very good molecule. It's available in low doses of 2, 4, or 6 milligrams. The biggest problem with tizanidine is the drug-drug interactions. Antibiotics which we commonly used for urinary tract infections, they're called fluoroquinolones. So ciprofloxacin or moxifloxacin or levofloxacin, these medications need to be avoided if you're taking tizanidine. If you have to take the antibiotic, at that time your doctor or your pharmacist will tell you to stop taking tizanidine for a few days until your antibiotic treatment is over. The reason for this interaction is that these antibiotics, they potentiate the effect of tizanidine. Tizanidine also has a side effect of reducing the blood pressure. So it can reduce the blood pressure, cause hypotension, and if you're taking these antibiotics or any high blood pressure medication, your blood pressure can drastically go down. Some of the anti-anxiety medications, they help reducing not just the anxiety, but they also relax the muscles. So when they relax the muscle, they could be used for spasticity. So the most common ones which we use is diazepam, or the brand name is called Valium. So Valium is very effective in treating the spasticity. The problem is the addiction, the sedation, and it also adversely affects the memory. So people who have high affinity for building drug addiction, they need to avoid that. Also, the drug tolerance and physical dependence develops very quickly with this medicine. What that means is if you're taking 5 milligram diazepam, which is helping you now, in a month or two, 5 milligram will not do the trick. You might need to increase the dose. So these are very common problems with benzodiazepines. Antidepressants. So antidepressants also are being used for pain management, particularly neuropathic pain. So tricyclic antidepressants, which is one of the oldest categories for antidepressant medications, is considered the first line for pain in people with or without depression. So if somebody has depression and they need painkiller for neuropathic pain, so this category of medication can be really awesome. But if they don't have depression, even then it is being used. So one of the oldest medications in this category is called amitriptyline, or the brand name is Elavil. So it has been studied in people with spinal cord injuries, very well tolerated and safe, viable option for SCI. Some of the adverse effects of this medication are not that good because it can cause bladder retention, it can prolong QT interval. What that means is it can affect the rhythm of the heart. It can cause dry mouth, blurred vision, and also sleepiness. So because of sleepiness, if it is dosed at nighttime, it can minimize the interference with your quality of life and improve the quality of sleep. There are two other tricyclic antidepressants called nortriptyline and desipropane. They cause less sleepiness and they have fewer of the anticholinergic effects like bladder retention or dry mouth or blurred vision, but they have not been studied in people with spinal cord injuries. So you may want to discuss that with your doctor if you want to try those medications. Another category of antidepressants called SNRI, which is serotonin norepinephrine reuptake inhibitor. An example of that is duloxetine, or the brand name is called Cymbalta. That also has been used successfully for neuropathic pain, and both tricyclic antidepressants and SNRIs help relieve the fibromyalgia symptoms as well. Okay, so anticonvulsants, or these are also called medications for seizures or epilepsy. So some of the anticonvulsants have helped with neuropathic pain as well. Once upon a time, lamotrigine, or the brand name called Lamictal, was considered as first-line treatment, but now we have two molecules, gabapentin and pregabalin, which work much better with less side effects than lamotrigine and other anticonvulsants. Gabapentin and pregabalin, so the brand name for them in America are Neurontin for gabapentin and Lyrica is the pregabalin. Both have replaced all the older anticonvulsants which we use for neuropathic pain. 3 of them are FDA approved, so we are adding Tegretol or carbamazepine with gabapentin and pregabalin. Pregabalin is also approved for fibromyalgia and neuropathic pain related to spinal cord injury. So let's look at Lyrica. So Lyrica is considered the first-line treatment for neuropathic pain. It has been approved for neuropathic pain in over 100 countries, is generally well tolerated, and some of the common side effects are anxiety, restlessness, trouble sleeping, panic attacks, anger, irritability, agitation, and aggression. It also has a black box warning, which is a serious warning of suicidal ideation. So if somebody is taking Lyrica and they start to feel like committing suicide, that is very, very serious and need to be addressed immediately. Gabapentin. So before I jump onto gabapentin, just a reminder, both Lyrica and gabapentin, they need to be started at a slow dose and as tolerated, and as the effect is desired, the dose need to be gradually increased. And once you want to taper them off, they need to be tapered off gradually as well. Lyrica or the pregabalin is actually a brand name medication. Generic is not available yet, so it costs a lot more money than gabapentin. Lyrica is also a controlled medication, so there is an element of causing physical dependence or addiction with Lyrica. Let's talk about Neurontin or gabapentin. It is widely used for neuropathic pain and spinal cord injury. Gabapentin as a single medication is also very helpful. However, gabapentin is being abused out there on the street. It is not a controlled medication in most of the states in America, but it causes that euphoria or little high for people without reducing the pain as well. Because of that, it is being abused. Usually it is dosed 3 times a day. So 600 milligram 3 times a day is a recommended dose for neuropathic pain. Just a reminder, your doctor might start you at 100 milligram or 300 milligram 3 times a day before bringing you up to 600 milligram 3 times a day dose. If somebody has kidney issues, the renal insufficiency means the kidneys are not working well enough. In that case, the dose need to be reduced. Some of the common side effects are drowsiness, dizziness, confusion. Some people experience nightmares. That's why we recommend starting at a low dose, let the body get used to it, then we can increase the dose slowly. It can cause ataxia, which is loss of control of body movements, and sometimes swelling in the body, edema. Local anesthetics. So as the name shows, local anesthetics means they anesthetize the skin locally. So most common old medication out here is lidocaine. So lidocaine patches and gel, both are available. Lidocaine patches was available under the brand name Lidoderm, but now it is available as generic, so they are not as expensive as they used to be. Gel can be applied on the skin, right at the place where the pain is excruciating. Diclofenac is an NSAID, non-steroidal anti-inflammatory drug, but it is available for topical application. So it is available as a gel in the brand name Voltaren and as patches called Flactor as the brand name. Now these brand names are available in America. If you are from other countries, which I see many of you are from many other countries, so your brand names might be a little different. But check with your pharmacist there. They would be able to help you out. Diclofenac 1% gel Voltaren is available as generic, so it is also not as expensive as Flactor patches, which is still a brand name. Bengay patches are over the counter, which contain menthol and methyl salicylate. So these are usually used for joint pain, superficial pain, which is more on the skin. There's one over the counter product available called capsaicin. So capsaicin reduces the post-spinal cord injury pain when applied on the skin. So I just wanted to add that in here. Okay, so opioids. So opioids work very effectively in modifying the pain message in the brain. However, in recent times, they're very controversial because of the addiction issue. A lot of opioid overdose deaths have happened. They also cause breathing problems, so they depress breathing. So people, when they overdose opioids and they die mostly because of respiratory failure. People with spinal cord injury also have difficulty breathing depending on the level of injury. So we really don't want to recommend opioids for people who are already having difficulty breathing. These medications also cause constipation, so we are increasing the comorbidities if we are giving opioids for spinal cord injuries. As I mentioned, tolerance and dependence happens very quickly with these medications. There was a survey which was done with more than 1,000 people. They collected all the data from the medical and the pharmacy world, and they found people with spinal cord injuries were taking high doses of long-acting opioid painkillers, and they were also taking short-acting long-term tablets in the opioid, the short-acting ones. Okay. So this leads us directly to our topics in the next two webinars. So next webinar we'll talk mostly about the opioids and how do they work and how can we minimize all the problems with opioids. And in the third webinar we'll talk about tapering of opioids and marijuana, cannabinoids, or all other non-pharmacological interventions. So I'd like to close here with a reminder about the medication safety. So considering MTM, so Know Your Pharmacist, Know Your Medication is a slogan from American Pharmacists Association. So knowing your pharmacist, asking them questions, and knowing your medicine is very, very important. Because if you're taking the medicine blindly trusting whatever doctor has prescribed, pharmacist is not giving it to you is not a really good idea unless you play as an active team player. So MTM stands for Medication Therapy Management. In America, if you are on Medicare or if you take more than 5 medications a day, you might be eligible for MTM session. So you can sit down with your pharmacist who will go over each and every medication of you. They can identify the gaps in your therapy. There might be some therapeutic duplications. They can go over what medications are sitting in your cupboard which are possibly expired or they don't work anymore for you. So all those things are strongly recommended that you go over with your pharmacist. And just a reminder, pharmacists are the most easily accessible medication experts available out there. So please ask questions from a pharmacist. Pharmacists like to answer any clinical questions when they come their way. Second reminder, never share your medications with anyone. The medication which has been prescribed for you is based on what your clinical condition is. So also it's illegal to share your medications with other folks. To use medications safely, please take them as directed. What that means is if the doctor has prescribed your medicine to be used twice a day and sometimes your pain is too high and you take the third dose, do let your doctor know. And if it is happening very frequently, have them document that on the prescription. So doctor can write, say, take 2 or 3 tablets once a day. So in that case, when you run out of your medication before, if you got 30-day supply but you run out on 25th day, you will not be flagged as a drug seeker. It happens to many of my patients when their doctors verbally will say, yeah, you can take extra pills if you want, but it's not documented in the prescription. So it's very important that doctor, pharmacist, and patient, they work as a team and is well documented. Accepting the counseling from the pharmacist. So in America, it's required that when you pick up your prescription at the pharmacy, pharmacist or the cashier will ask you, do you have a question for the pharmacist? So please say yes and ask them, what do I need to know about the medicine? There's always something new to learn. The science keeps advancing all the time, so we have new data coming in. That all gets included. So unless you ask the question specifically from the pharmacist, you probably wouldn't know about it. And read the monograph and the information which comes with the packaging, with a prescription. So when you read the monograph, it'll educate you and be a better consumer. The last but not the least point on this slide is about the reporting of adverse drug reactions. Adverse drug reactions are not 100% reported. Actually, one place I saw said less than 5% of the ADRs, adverse drug reactions, are reported. So if you're experiencing a side effect or adverse drug reaction, which is not comfortable, you can go to FDA website and log your side effect there, or you can call 1-800-FDA-1088. So again, you can easily go online from anywhere in the world and enter your adverse drug reaction which you're experiencing. Safe disposal. So FDA website has recommendations for safe disposal of medication. So if you have a medicine which you don't need anymore, or it might be expired, you want to get rid of this medication from your home as quickly as possible. So that will reduce the chance of any accidental poisoning, or if somebody is intentionally trying to misuse and they try to break into your house or steal the medication, so all those can be minimized if you can dispose of the medication properly. In America, 4 times a year, we have medicine take-back days. So that information is available on DEA website, how to dispose of, where those disposal medication take-back places are. And you can give them the medication without any issues. There are also some permanent collection sites in many cities and towns in the country. So you can go to some of the pharmacies, you can dispose them off in police stations or even transfer stations. Disposal in the household trash is also a possibility, not really recommended, but if you don't have access to medicine take-back days or permanent collection sites, what we recommend is you do not crush the pills, you keep the medicine intact, mix it with coffee grinds or coffee litter or something which will make it obnoxious, put it in a plastic container and throw it in the regular household trash. But do not throw your medication in your household trash without mixing it with something obnoxious. Otherwise, pets or somebody else can get into the trash and use those medications. And we used to recommend flushing medications in the toilet. We don't do that anymore, but FDA has a list of some dangerous medications which you can flush in the toilet if needed, if you don't have other options available. Okay, as I noted in the beginning, this webinar is being recorded, and if you are listening to it recording afterwards, whatever information I just shared might have changed. So please continue to do your research, keep yourself updated. Your health status might change, so you want to be asking your healthcare provider on the regular basis. So it's very important to stay educated. So I got 3 resources for you. One is ChristopherReeve.org. So Christopher and Dana Reeve Foundation has tons of resources for people with spinal cord injuries. There's a paralysis resource center. There are webcasts, webinars, podcasts, forums, blogs. So a lot of resources which you can even think about. They're all there. Drugs.com has a lot of information about drugs. And last but not the least is KnowYourMeds.com. So KnowYourMeds.com not only has information, they have downloaded all the WHO database as well. So they have information about drugs from all over the world. They also have support for the adherence. So once you enter your med list, which you can do anonymously without giving your personal information, it will give you reminders on what time to take the medicine. So it will come as a pop-up with the app on your phone itself. And just as a disclaimer, KnowYourMeds.com, I'm on the advisory board of this organization. So just to summarize what we talked about, know your physician and know your pharmacist. So having open discussions with them, considering them as a team member for you in your journey to health and wellness. The second is if you have new pain or pain gets intensified, please report that immediately. Just don't continue to suffer through that. Know your medications, so learn about them and keep your knowledge updated about the medications. Use medications only as directed by the providers, by your prescriber. Have your medications reviewed regularly. In America, if you are eligible for MTM, usually most insurance companies will pay for one MTM visit once a year. So have them regularly visit, review all your medications, dispose of past medications or expired medications properly, research non-pharmacological interventions, which we are going to discuss in detail on part 3 of this series. Also, you may want to connect with other people who have experience of pain. So we have a peer mentoring group, a support group available through Christopher and Dana Reeve Foundation. So if you go to christopherreeve.org, you can get information about that. And please register for part 2 to learn about the opioids and more details about those on February 20th. Okay, so now we are open for question and answer. I'm going to actually slide up and look at all the comments and questions which came in. So please type your questions in the chat box, and if you would like to speak it, maybe we'll have possibility at the end of the webinar as well. So first question I'm reading is, what is the best way to control neuropathic pain besides ignoring them and concentrating on something else? So yes, distraction is good, but we have a lot of options I shared. So I think this question came before I started to talk about neuropathic pain. So hope this answered your question. If not, please post your question again and I can go in detail about any of the questions or any of the doubts you might have. Any feedback on use of medical marijuana is the next question. So yes, we will talk about medical marijuana in the third webinar, which is going to be in March. Next question I have is, I have terrible neuropathic pain for last 18 months. I have tried medical marijuana but has not helped. I have been living on Percocet 10 milligrams. Okay, so as I mentioned, for the neuropathic pain, we have antidepressants, we have pregabalin and gabapentin as first line, we have antidepressants and anticonvulsants. So please look through those names, and amitriptyline could be an option, pregabalin or gabapentin could be options. Hope that helps. That will definitely help better than Percocet, because Percocet is not recommended for neuropathic pain. The next question I have is, I'm going to read it quietly. So this is a medical question from a person who is paraplegic, left side, lot of pain. So it's a very specific medical question. I would recommend talking to your medical doctor, because just over this webinar I cannot really give an answer, and I'm a pharmacist, I'm not a medical doctor, so I can talk about medicines a little bit more, but please check with your local provider there. Next question is, CBD oil, will it be covered? Yes, we'll talk about that in webinar number 3 in March. So this is a question related to an injury. Sounds like musculoskeletal pain for his wife, rheumatoid pain, as well as possible injury, could be neuropathic pain as well. So I hope you can talk to your doctor about it. In the webinar I gave you a very comprehensive overview of all the medications we have available. But trying out different options in consultation with the doctor of your wife would be helpful. Feel more pain while walking and lying on bed. Okay, so yeah, it just needs maybe rest and some medications which are probably for neuropathic pain here. The next question is, I have a long history. So Robert, I see your question, but I don't really see any comment afterwards. You said you have a few questions, so if you want to post them, that will be great. Next question I'm reading right now. Rachel is asking, what is the mechanism of action for antidepressants to work? So as I mentioned, there are two categories of antidepressants here which work for the neuropathic pain. One of them is tricyclic antidepressants, and the other one is SNRIs, which is serotonin norepinephrine reuptake inhibitors. So what that means is they work with the neurotransmitters, particularly serotonin and norepinephrine, for reducing the feeling of that pain. There might be more mechanisms of action with more neurotransmitters, but that's what I could think of right now. Reading the next question. So Matt's question about sitting. So while seated on a wheelchair for pain for long time, so it could be either one. So depending on, yeah, you said it's not burning, it's not shooting. Sounds like musculoskeletal pain, but that will be your doctor's decision on that. So please work with your doctor, because again, I'm on a webinar, I'm not able to see you, and I'm not a doctor. So depending on the diagnosis they make, depending on the medications you take, you would know what kind of pain that is. Also, if you take medication for neuropathic pain while you don't have neuropathic pain, it may not really help, and vice versa. So that's another way for your doctor to diagnose if they're not able to see anything in the x-rays and all the diagnostics they have done. The next question about the disposal of cancer drugs, same thing, Debbie. If you go to the FDA website, they will tell you there are dates available 4 times a year, sorry, where you can dispose of all unused drugs. And you can also check with your local town or city if they have any transfer station or local pharmacy or a police station who will take the medications back. Of course, they need to be disposed of carefully, because as we know, all these drugs are chemicals, and if they go into the regular on our planet, in our soil or water, they can be dangerous for people who do not need those medications. Next question is, Know Your Meds app, is it free or there is a charge? The app is free of charge. They have a premium version as well available. I don't remember how much is the charge, but that's only if you want to get more personalized information about your medicines and stuff. I think the information is all free. Your own chart, if you want to make that and get the pop-ups reminders, okay, it's 9 o'clock, you want to take this medication, 11 o'clock you take the next medication, so it will give you the name and the timing of each medication and when do you need to order them. Everything is there, and that's part of the app. I know is free. The next comment is on venlafaxine, which is an antidepressant for neuropathic pain management. Yes, venlafaxine can be effective for pain management, neuropathic pain management, but from the studies perspective, what we know is the Cymbalta or the duloxetine, Lyrica, which is also called pregabalin, or Neurontin, which is called gabapentin, these might be more effective. But if venlafaxine is working well for you, that's great. Next question is about how to avoid running out of pain meds during a disaster or as an emergency. So that's a very wide question. It depends on the disaster, depends on the emergency. Only thing I know is whenever we have an upcoming snowstorms, I'm in northeast of like Boston area. So usually pharmacists do not mind filling prescription a couple of days early, so people do not run out of their medications. If it is a big storm or hurricane and stuff, I know most pharmacies will open up their pharmacies as quickly as they can. I know cases where pharmacies have given out medications without billing the insurance companies, and they will bill the insurance companies later on. So that I think you will have to check with your local pharmacist to see what options they have to offer to avoid running out on the pain medications. Next question. So the question is about methadose, and I'm not familiar what methadose is. I'm assuming it is methadone maybe. So methadone is a opioid agonist, antagonist pain reliever. So we'll touch base on that in webinar number 2 a little bit, but I don't recall it has any effect on neuropathic pain. Next question. What type of medication would be most beneficial for fibromyalgia? So if I remember correctly, pregabalin is considered the first line for fibromyalgia. There are other medications which might help, but it is considered in the category of neuropathic pain, which I already covered. Question. So next question is about benzodiazepines like Valium and opioids, somebody who is completely dependent on them. What can be done? So it's a tough situation. There are a bunch of options available. We'll discuss all those in the third module, in the third webinar, which we'll be conducting in March. Seeing another question, I have a question about painkillers. I have a question on Endoset. I think I answered that. There's a bunch of questions about the PowerPoint and the webinar, if it is going to be available. Julie, do you want to take over those questions?
Sure. As a reminder, we're recording this presentation, so it will be up on our YouTube channel by the end of the week. And you can watch the whole thing there with including all the visuals.
I'm reading another question here. So the question is about an injection, which I'm assuming is going into the vertebral column. It could be a corticosteroid, but I would not be able to answer that question unless I know what the medication was. Of course, as you know, all medications have side effects. So if you have any specific question, I think you guys can email me. I would love to answer your questions on email, or if you can email me those questions now or later, we might be able to answer them in the next webinar as well. So thank you very much, everybody, for attending the webinar, and I appreciate all your questions, and I hope it was helpful. I would like to thank Christopher and Dana Reeve Foundation again for sponsoring this webinar, and I look forward to connecting with you in February. I think it's February 20th, sorry. Thank you.
And this concludes today's conference. Thank you for your participation. You may now disconnect.